Did anyone get a pop-up saying that it was going to be recorded?
This meeting is being live streamed, just popped up on mine,
Okay.
but that's different.
It's live on the MGA website, so I'm guessing
I think that live stream
live there.
might
It's
be the
recording.
same as recorded.
Yeah.
Excellent. Shall I start?
Yeah, I think let's go ahead and start. Sorry about that. Would you like me to do a quick attendance call, or do you have remarks before I do that?
Just quick remarks. Thank you. As per usual, I want to thank our staff, both Lindsay and Amberly, and there could be other DLS employees. I'd like to thank all of you for your time. And when we try to fix problems, what we don't have is time, and yet here we are having to come together. So I do appreciate you being here. I appreciate all the boards that sent over a presentation. I think today will be a very good day of getting on the ground floor or getting on the same floor. I think people have different, maybe different words or different understandings, and certainly not fully understanding what some of the other boards do. So I think hearing about that unique part. And so I thank you all for doing the highlights of what is unique about your board. I do think over time, and maybe it's just me, but thinking that at some point we need some other consistent maybe measures across the from all the boards just to know where we're at on a few metrics. But I think that's later, and I don't mean to do a deep dive of any sort. But I think that might be important as we move forward in our analysis. So I know today we have a presentation from DLS with an overview which gives some history. So for some of you it will be old, and I apologize. For others it will be new. And then hearing from all the boards. So again, thank you all for sending in what you did. So let's move on. Thank you, Lindsay.
All right, thank you, Delegate Kaiser. So I'm just going to do a quick roll call and for the members of the commission. And I know we've got a lot of guests today. Thank you for joining us. If you are a guest, not one of the core members of the commission, if you could put your, actually, do we even have a chat? Yes, we have a chat function. If you could put your name and affiliation in the chat, just so people have some context later, if and when you're speaking, that would be great. So Delegate Kaiser is here. Clint Hackett.
Here.
Meg Sullivan.
Here.
Rhonda is not here, but Dr. Forbes Scott, I believe, is here from the Board of Nursing.
Yes, I'm here.
Thank you. Christine.
I'm here. Thanks.
Dina's here.
Yes.
Karen.
Yes, I'm here. Thank you.
Stacy.
Present.
Lori.
Here.
And Tiffany.
Here.
That's great. 100% attendance, except we are still missing a Senate co-chair. If and when we get one, I will let everyone know who that is. All right, so unless anybody has anything else they wanted to share before I get started, I'll jump into the DLS portion of the presentation.
This is my ignorance showing, but I don't see a chat box on there. I'm used to Google, but I don't see a chat box on the Zoom thing.
Oh, I'm sorry. I see one at the bottom. Is that a function of me being the host? Does everyone
I see
else,
participants,
anyone else
raise
have it?
hand, share,
I
and
don't see it
more.
either.
Oh, all right. I'm sorry. I apologize. Well, then just please raise your hand if you'd like to speak and start with your name and your affiliation if possible. Thank you. All right, Lee.
Okay. Yeah, Lee Broderick. I'm with the Board of Environmental Health Specialists.
Thank you. And so I'll start sharing my screen in a moment. All right. Can everyone see DLS presentation? Somebody thumbs up?
Yes, we can.
Yes.
Okay, great. Thank you. All right. So hopefully we'll see how this does. As I'm the host, I might not be able to admit people, but I'll do my best. So the agenda for today, Delegate Kaiser already sort of started discussing this. We were going to start with a DLS presentation. This was prompted by some questions that were raised at the last meeting to give a background. This is going to be very high level overview of the history of health occupational regulation in the United States, models that other states are doing around the country, and then some of the stats of the Maryland Health Occupations Boards, just to sort of help put everything in context, and you know, sort the relation, that sort of relationship between the boards. And then we'll get to the presentations from the individual health boards, which is meant to be, just a very quick couple of minutes showing the unique aspects of each of the health boards. Sorry, I'm just going to respond to ITO, letting them know I did it. Thank you. 'Cause that was my emergency help. I can't get online. All right, so the history of health occupational regulation in the US is very much going to be, and Christine might appreciate this, is really a history of the regulation of medicine, because the regulation really originated with looking at regulation of physicians. They were the first occupation that was regulated, and that sort of paved the way for the other health occupations, and also that set the stage for how health occupational regulation was going to be modeled in the US. And you'll find, a lot of states tended to do the same sorts of things. There started to be some splits that we'll get into later, but like I said, this is really sort of the story of medicine as the basis for health occupational regulation. So regulation really started through the 1700s. New York City was the first licensing law that required an examination before practice, but very much at that point, the structural model was regulation by those who were in the profession themselves. That the idea was that the folks who were practicing medicine would regulate other people practicing medicine. They would, sort of the history of like a guild, right? That they would regulate themselves because they knew the field and they were the best suited to regulate others entering the field. And so in Maryland, that really started in 1798. This was fun for me because I hear about MedChi, but I didn't understand the origin of the name MedChi. So Maryland passed a bill 1798 to establish a group essentially to regulate medicine, which is where we got MedChi from. They were organized the next year, and that was the 7th state medical society that was established in the country. Oops, there we go. So MedChi, once formed, then they established a medical board of examiners. It was geographically diverse board, and that board of medical examiners was made up exclusively of physicians at the time. There weren't at that point a concept of consumer members of the board. The Maryland also established a medical school. It's now the University of Maryland School of Medicine. And the legislature permitted MedChi to also award a form of licensure for practitioners who hadn't even attended medical school. Then in the mid-1800s, there was a movement in the US that was very anti-monopoly and anti-elitist movements. And that actually led to deregulation of medicine. There was also a rise of different forms of medical discipline, homeopathy, for example. And so Maryland passed a law in 1838 allowing any person to collect fees for medical services, which essentially meant you don't have to have a license. You can be a physician and you can charge for that service. And that was common in other states at the time. Then in the latter half of the 1800s is when the Supreme Court upheld that medical licensure was a valid exercise of the state's police power, and you started to get more state-based medical boards rather than these sort of like a private type of medical board. These were state-based medical boards that started to pop up in the latter half of the 1800s. In Maryland, that meant that the State Board of Health was authorized to license physicians. At this point, it was more like a registration. There wasn't an exam requirement. And it also in that latter part of the 1800s, Maryland recognized this different approaches to medicine that existed at the time. So they created 2 examining boards, one that was representing the folks that were members of MedChi and a separate Maryland State Homeopathic Medical Society. Then other professions started being introduced very end of the 1800s, early 1900s. Maryland had the world's first dental school and created the Board of Dental Examiners in 1884, quickly followed by Board of Pharmacy, Board of Nurses. So I mentioned end of the 1800s, there started to be these independent boards made up of practitioners. New health professions were being added. I mean, it wasn't until the 1960s, 1970s that the US had this consumer movement and also an focus on open government. That's when Maryland passed an Open Meetings Act. Many states passed something similar, Open Meetings, Public Information Act type of bills. And that's when consumer members started to be introduced to these licensing boards. And then also the idea of like a review process for the boards. Colorado enacted the first Sunset Review in 1976. Maryland's came in 1978. It's essentially the current version that we use now was passed in 1984. So that's when you started to get much more of this concept of the boards are not just serving the practitioners, they're also supposed to be serving the public, the people who are visiting the practitioners, right? The patients. So that's when you get sort of much more of what the current model is. Maryland ended up abolishing the homeopathic board and set up a single board of medical examiners in 1957. They actually not originally, but in 1968, they had physician discipline assigned to a separate commission on medical discipline. And then 1969 is when they created the Department of Health and Mental Hygiene and brought the health boards under that department for administrative purposes only. Continuing on the sort of the story of physicians, there was a lot of pushback on the idea of physicians regulating themselves due to some high-profile news stories that came out in the 1980s. And so that's when you started to get the idea of sharing information between states. There was concern that physicians were moving between states and they would lose their license in one place and just move to another state. It's also when you started to get mandatory reporting laws about, that hospitals would maybe learn something about a physician and fire them, but never report it to the medical board. And so they would just go get a job somewhere else. And then I have here in 1988, Maryland merged the Board of Medical Examiners and the Commission on Medical Discipline into the State Board of Physician Quality Assurance, which is the predecessor to current Board of Physicians, and it ended MedChi's role in appointing members to just directly to the board. Some other states moved in the opposite direction by separating discipline from licensing. New York is a notable example. So that's when you start to, again, I mentioned these high-profile news stories that were coming out in the 80s. So states reacted in different ways as far as how to approach that discipline and licensing, whether or not those should be conjoined activities or separate activities. So I've linked here a report that I thought was very helpful from the Council on Licensure Enforcement and Regulation that identified 5 models that the health occupational boards around the country are using today. They categorize them as A, B, C, D, E. A being fully autonomous and independent, B, autonomous with a central agency for administrative functions, C, autonomous for decision-making, but a central agency responsible for administration, budget, personnel, investigations, and discipline. D, a central agency with decision-making authority, but with boards delegated responsibility for some functions. And then E, a central agency with final decision-making authority. And the boards are really serving in an advisory capacity. And so that's very interesting when we're looking at sort of what model other states have pursued today. Maryland's survey response, whoever it was who was filling out that survey when they did this in 2025, Maryland said it uses a combination of A, C, and D. And so that might be an interesting point for discussion here today. Had I been filling out the survey, which is not appropriate. I would have thought to say C. That's what I would have thought for Maryland. But the idea is some boards are a little bit different and some are, operating perhaps much more under MDH authority than others. There's also, Maryland chose to say we have 3 different models that are operating in the state. Some jurisdictions listed only one model. That was the majority. 20 jurisdictions said they use one model. 15 said 2 models, and 11 said 3 or more. So Maryland falls into that category. So regardless of the number, if you said 3 or just 1, C is the most common model that's being used around the country. And by most common, of 50 jurisdictions, not quite all 50 or 50, there should be more than 50 jurisdictions because DC perhaps certain states are using more than one model, but it sees the most common. And this is just a graphic representation of those models. Not everyone did respond. And I have here listed the model types for nearby states because we're often particularly focused here in Maryland on what other states are doing. Pennsylvania, for example, is one of the states that didn't respond to this survey. So I don't have their list of models here. But this is, like I said, just sort of an overview of how the states, given that sort of history, which, like I said, very much a focus on the history of the regulation of medicine in the country, but how that has helped shape the models that states are using now to regulate health professions in the US. And I'm going to turn it over to Amberly. There we go. Who's going to talk about sort of the picture of the Maryland boards now?
Yes, so our last meeting we talked about comparing, obviously we're going to talk about some of the unique differences between the boards, but also some of the basic data of just licensee types. We can look at budget information, authorized pins, different things of that nature. So I included some information here for fiscal 2025 of the number of licensees and certificate holders per board. We're split on 2 pages here, but you can see these are some of the boards that I guess oversee fewer practitioners on this page, dental being high, but we see over here the nursing board oversees a lot, as well as physicians. So some of our older established boards, from what Lindsay said. And then if you want to keep going, we can compare also new licensees to renewal licenses. And this data comes from the MFR, so it may not be as, the most accurate data we have now. Obviously, some of your presentations have more recent figures, which is really helpful to look at, I guess, board growth as well. But as we, I guess, go on.
Could I just interject real quick also? Also, if you're looking at these renewal figures, note that many boards have like biannual renewal. So that's only going to represent half of their renewals, or maybe not half exactly, but a portion of the renewals that they're doing every 2 years.
That's a good point. Yes, so just more of the differences between the boards, that license figures aren't just one picture when we're thinking about board size or unique challenges, or really interested to hear what everyone has to say.
Thank you both so much. I appreciate it. Are there any questions for Lindsay or for Amberly based on the presentation? And then I'll ask a follow-up for all of you. Is there anything you would have wanted to learn about in that history or understanding of how the board started and how they kind of went on different pathways, or anything about that? If there's anything that people want to learn about more in the future, is there anything to follow up? All right. I'm going to hand it back to you, Lindsay. I don't know what order you have, but whatever order it is, whether it was first come, first served. I just remind everyone that these were supposed to be 2-minute presentations. So I feel like after 5 minutes, I'm going to jump up and down and wave my arms. So just trying to keep it brief. And then, of course, allowing for, I think, questions between, so someone doesn't lose the particular thought if someone from a board says something that really sparks someone else's interest. So just want to keep it moving so we have time for those questions, because we also at the end have to talk about the game plan. So Lindsay, I'm muting myself. Back to you.
Okay. Well, at the risk of perhaps confusing myself, what I'm going to try and do, I've made a note of everyone that I've heard from. So certainly if you're here and I didn't hear from you and you want to present, that's great. And just raise your hand. But otherwise, I'm going to kind of go in an alphabetical order of the list on the board of the boards. And that's going to mean I'm going to start with Tiffany for the Board of Acupuncture, but I know that she is also going to be speaking on behalf of the audiologists, the OTs, and the morticians. So also bear with me. I'm going to try and pull up presentations the best I can. And I'm already at a loss because I'm looking for the acupuncture one. They're not, I probably should have renamed these so that they would be in order. Oh, here's the acupuncture. Okay. So Tiffany, if you want to start and I'll just pull up as quickly as I can.
Sure. And I'm going to go a little backwards from what you put on the screen to the interesting historical facts. Prior to the 1970s, the practice of acupuncture was considered a criminal offense in the United States, and mainly due to the fact that needles were used to penetrate the skin. So practitioners risked being arrested, fined, or caught up in a legal raid to be carried off to court. Public demand exploded for acupuncture in the 1970s after a New York Times journalist wrote a story about his treatment and how the acupuncture relieved his pain and, after an emergency appendectomy. And not long after that, President Nixon went to a visit in China, where he also did a little bit of information about medical treatment in China, which also piqued the interest. So Maryland is one of the first of 3 states in the nation to pass formal acupuncture regulation. I believe the first state was Nevada, and I believe in Nevada that acupuncturists are actually considered as mainstream practitioners, so they're a part of the overall health model there. And California definitely is a big second. In 1974, the founders, Diane Connolly and Robert Duggan, incorporated the College of Chinese Acupuncture in Maryland, and it has changed names many times. You all probably know it as Thai Sophia. It was Maryland University of Integrative Health, and now it's a part of the School of Integrative Health at Notre Dame of Maryland. But for the purpose of the presentation, we'll stick with Traditional Acupuncture Institute. The Traditional Acupuncture Institute in 1985 became the first school in the United States to get formal accreditation from our NCCALM, which is now NCBAHM, the National Accreditation Board for Acupuncture and Oriental Medicine back then. And in 1986, the Maryland Higher Education Commission approved TAI to award its first formal master's degree in the state of Maryland. With all that being said, our roots, as Lindsay presented, actually goes back to the Physicians Board. We were under the Physicians Board as of 1982, when the Maryland legislature required that anyone practicing acupuncture be registered. And it wasn't until 12 years later in 1994 that legislation was passed to make the Acupuncture Board its own independent board. As of today, we have 1,369 licensees, which also include animal acupuncturists, and we also certify auricular detoxification specialist. That's unique because the training is a 5-needle protocol, and it allows nurses and counselors and therapists and psychologists to perform that service for people who are fighting addiction and have correlated issues related to addiction. We average about 10 complaints a year, and we complete at least 90% timely. There's always one for some reason that carries over to the next fiscal year. On average, we do 118 new applications, with all of them being approved within 10 days of receiving the last certifying document. And we average over 500 renewals, with 95 to 100% of those being completed in 10 or less days as well. Some of the accomplishments since I joined the board in 2022 is facilitating the Health Occupations Board's migration to a VoIP telephone system, contributing to the ADA compliance strategy, which was a big deal a few months ago, eliminating manual payment processes when I got to the board, which also helped resolve a concern from the auditors in a previous audit. And of course, updating regulations, adding acupoint injection recently, and statutory guidelines as well. Moving forward, the board is beginning to use the National Practitioner Data Bank as an additional screening tool, not just as a means to report public discipline that has already been executed. In 2027, we will begin doing criminal background checks for new applicants, and following that for renewing applicants in 2028. Working with all of the boards and MDH on the need to upgrade our IT system. The board is going to seek making a name change so that it better reflects everything that the board regulates, which is not just needles. And we have a good stakeholder engagement based on scope infringement and unfortunately worker exploitation. So we plan to do that and be able to formalize the work that comes out of that. And my last fun fact is that the Board of Acupuncture actually doesn't just regulate needles. So we include any part of East Asian medicine, which are traditional therapies like moxibustion, cupping, gua sha, body work, not traditional massage, is East Asian massage, herbal medicine, dietary therapy, and mind-body exercise. As well, there are some modern modalities which include acupoint injection. I speak pretty quickly, so I'm open to questions.
Any questions? I do want to ask a question, a quick question, or maybe it's not so quick, but when you mentioned the non-needle part, all the list of East Asian things, and which I couldn't track when you said it, how many members of your board represent that part of the profession?
It's a mix.
Okay,
It's a big mix. Most of our board doesn't just do needles.
okay,
But most of our board also are professionals in other modalities as well. Some of them are also psychologists or nurses, so they're duly licensed.
gotcha. Thank you. Any other questions?
You muted yourself,
Delegate
Delegate.
Kaiser, you're muted.
Are we back to Tiffany for a few more?
Yes.
Okay.
I don't believe that I have a visual presentation for the audiologists or the occupational therapists, but I do have one for the morticians. So I'll leave it to you where you'd like to go next.
I will do audiology quickly. And occupational therapy is just a brief statement. The Board of Audiologists, Hearing Aid Dispensers, Speech Language Pathologists, and Music Therapists, as you can tell from its title, is a board of multiple modalities to do with hearing. And they protect the citizens of Maryland by making sure they license qualified and competent therapists in those practices. Skip down for a minute. As of July, they have 5,931 active licensees, and they issue about 50 licenses per month. Their governing board is 15 practitioners, 3 audiologists, 3 hearing aid dispensers, 3 speech language pathologists, 3 ENTs, 2 music therapists, and 2 consumer members. The board currently has 4 staff members doing this work. They have an open session meeting that occurs on the 3rd Thursday of each month. They have 3 main operating committees. And I think the rest, I know Kina, as far as accomplishments is concerned, and she probably doesn't want to brag on herself, but she did come to a board that had a gap of service for an ED. So she's come in, and it was missing a lot of staff actually. So she came in, she has staffed everybody up. They're caught up on all their applications and their discipline. So the board is flowing pretty well now with Keena having been on board.
All right, any questions about Board of Audiologists?
And I will send this to you, Lindsay, because I think I have it in my email.
And then I think you were gonna make a brief comment about the OTs?
Yes, and I'm also doing residential childcare. So Lauren Murray is the executive director for occupational therapy practice. They license occupational therapists as well as therapy assistants. And I did not get her numbers from her. But she says that these talented and caring individuals work with patients of all ages, helping them to surpass any physical, cognitive, or developmental conditions that may keep them performing everyday tasks.
All right, I don't know if there's gonna be any questions, but I appreciate you helping out with the other groups. And who do you have next?
The Board of Residential Childcare.
Say it again?
The Board of, let me say it correctly, the State Board for the Certification of Residential Childcare Program Professionals. That's a mouthful. And the acting ED right now is Siobhan Pearson. Let's see where I want to start. In 2008, the board is the certification authority for residential childcare programs in the state. In 2008, the board's authority was expanded to include the certification of residential childcare workers employed by these programs. By the Department of Human Services, the Department of Juvenile Services, and the Maryland State Department of Health as residential child and youth care practitioners. The board's population of protection is children living in Maryland that participate in residential child care programs. Let's see. Of course, they resolve complaints from the public. They are the licensing authority. They work for courts, employers, insurance companies. Their board is unique in that when you work with children, everything that touches children, they also have to have a connection to. At present, they have residential child care professionals as well as program administrators, and they have 1,117 licensees.
Thank you for stepping in for all of those groups. Are there any questions about, I could not get the full mouthful of the residential childcare facilities or certification of, I think at the beginning. Any
It's a
questions?
doozy.
And then was there one more, Tiffany?
It is the Board of Morticians and Funeral Directors.
Okay.
I think Erica has logged on, but she may be trying to straddle two meetings because she had a scheduling conflict. So the Board of Morticians, inherent in its name, has an interesting job of, let's see, licensing, regulating, and doing enforcement for nursing homes, mortuaries, and the associated staff, crematories, and even their drivers. At present, there are 455 total establishments. Let's just say 57 corporations, 46 mortuary transports, 43 crematories, and 20 restricted facilities. And they recently added natural organic reduction and alkaline hydrolysis. What she didn't include on here, I think, is recently as well, the animal cremations are being transferred to her board. Her board has 12 members and she has 5 staff doing this work. And they have 1,700 active licensees. And the demographics are listed there on the slide. So they do field inspections, they do examination, administration, of course, complaint resolution, and then developing all the standard operating procedures that goes along with that. When Erica came on, there was also a void in leadership as well as staffing there. So under her leadership, she has become fully staffed. She's eliminated a backlog of inspections. And improved the statewide inspection program. She's improved the complaint processing rate as well as the resolution to those complaints. And she did have a public health emergency when she initially started. So she worked, I know, with the governor's office and stakeholders to resolve that as well. So in her role, she had a board that did have still a lot of paper processing. She has expanded electronic services and improved outreach. She's stabilized the staffing operations, and established key roles to continue that progress. She led the critical transition of the rollout of the alkaline hydrolysis and a natural organic reduction, which is a new industry to Maryland. So she is doing pioneering work. She collaborated with the Department of Health and the Department of Environment and OCO in order to accomplish that. She's working with her board to modernize the standards for regulation and to improve public safety compliance amongst the licensees. And if you skip to the last slide, she has a more detailed list of those accomplishments.
All right. Any questions? And I do want to thank you so much for speaking for the other groups, and probably not able to answer too many questions for them, but maybe you could. But does anyone have any questions before we move forward?
I just
All
want to
right.
say something quickly about the Board of Morticians is legislation did pass this year to transfer. There was a weird thing where some cemeteries were overseen by the Office of Cemetery Oversight. Now they're all transferred to the board. Because it had something to do with like ownership, but now, so I think there's a handful of more
Crematories, yeah.
oh, crematories, sorry, yes, that they'll
Yeah.
oversee. So they're kind of expanding their oversight.
Mm-hmm.
All right. Who's next? And Lindsay, actually, not just who's next, but I mean, I guess if you could say who's next and maybe who's after that, so someone knows they're almost up and so forth. On deck.
Yeah, so the next one I would have is the dental examiners, and then we'll move to the environmental health specialists. I am pulling up the dental examiners presentation. Can everyone see that?
Yes, we can.
Stacy, ready?
I am.
Okay.
Hello, everyone. I am Stacy with the Maryland State Board of Dental Examiners. I did submit my full report. However, I am only going to speak on the second slide, this one here. So the unique features of the dental board is that the dental board is the only board that uses an annual balloting process in selecting its board members. So those appointments have to be voted on by the dental community. And no other board has that. And that it does come to at a cost for our board. The board is being forced to relocate due to unhealthy work conditions. We're right now located on Wade Avenue down in Catonsville, on the Spring Grove campus. And if anyone has ever been there, our board faces mold. We've had bouts with Legionella, the rodent issues. We have been working under some pretty horrid conditions, so we will be relocating next month to a location in Owings Mills. So we're really happy about that. Our dentists are consistently identified as high risk for the healthcare profession regarding the suicide rate. So when we look at our cases, we look at them through a lens of, how we're handling our dentists as well. We fully fund our dentist well-being committee. and they were awarded the Golden Apple Award for Excellence. We fund them at a pretty high rate, so that comes directly out of our special funds. We carry an unpreventable backlog, and that's due to our MFR being set at 270 days. The way that our process runs, it does not allow us to manage our cases within that time frame. Annually we get over 250 cases, and our average days to close right now is sitting right around 220, a little over, close to 300. So we're, the majority, our public action, expert witness, and prosecution are all over 350 days to close. So with the other smaller, it just doesn't average out to fall under 270. So we sit in a position where it's almost impossible for us to make that number. The dental board also utilizes a triage process to initially review complaints. No other board does that, but we do it so that we can make sure that the complaints are thoroughly being looked at before we send them over to the discipline review committee. We have 3 biennial calibrations: anesthesia, infection control, and expert witness. And we found this to be helpful in making sure that everyone is on the same page when it comes to information and how the offices operate. The dental board issues over 40 different licenses, certifications, permits, and recognitions. And we've done that over the past 3 years at a 100%. So all of our licenses and renewals are processed on time. The dental board collects over 75 different types of fees. We've remained solvent beyond the prediction of bankruptcy in 2025. The dental board right now is operating at a bare bones staffing, and also in terms of our spending. We've cut back just to try to remain solvent. We're at the point of, I purchased my own ink for my printer. So we are really working hard not to overspend in any area. And the last thing that I will mention is that the dental board has not had a comprehensive fee increase in 13 years, which is why we are sitting in the financial situation that we are. So those are some of the unique features of the dental board. But like some of the other boards, we do have our compliance unit, which we have 3 investigators, and they are solely responsible for investigating those 250 plus cases annually. The dental board right now only has 11 employees, which sounds like a lot in comparison to some of the others, but with the complexity of our cases and our workload, it's not nearly enough. We definitely need more support staff. So that concludes my presentation. You can look through the remainder of it at your leisure. I'm open for any questions.
Are there any questions? All right. I'm sorry, Lindsay, who did you say was next?
Environmental health specialists, and then
And
long-term care administrators.
All right, environmental health specialist. Thank you.
Yeah, I'm Lee Broderick. I'm the executive director for the Board of Environmental Health Specialists. And I kept my comments to verbal. And I thought when people talk to me about my board, I start with a little background on what our profession is, because not everybody understands. Like if you talk about nurses and physicians and physical therapists, everybody kind of has an image. But if you say licensed environmental health specialist, not everybody knows what that means. So I thought I'd start with that. So they're basically someone who applies scientific principles, methods, and procedures to inspections. They have regulations that they're enforcing, and they basically monitor, inspect, and regulate public spaces, food providers such as restaurants, grocery stores, and food processors, water supplies and waste disposal systems, public swimming pools, bathing beaches, and they even deal with animal vectors of human disease such as rabies. just to reduce the risk of our citizens becoming ill. And I think that's one of the things that makes us very unique is a lot of the boards are dealing with people after they have a problem. We're trying to keep people from getting ill or having health problems. So they work behind the scenes to control environmental risk factors before there is widespread community illness. And to do that, they have to meet certain minimal qualifications that has to do with the education and the amount of science classes they have to have, math, and so on. They have to do in training. And the process is basically somebody comes to us, they have their coursework submitted to us on transcripts. If it's international, they have to go through an evaluation agency. And our board staff review those. If they meet the qualifications, they're issued a certificate of eligibility, and they can use that to go look for a job. Usually, a lot of times it's in a local health department. And once they get the job, their sponsor sends their certificate back in with signatures, and it's converted into an in-training certificate. They have to work generally for a year before they take an exam, the National Environmental Health Association registration exam. And if they get a passing score on that, they actually get licensed. So that's kind of the licensees that we're dealing with. So the board actually consists of 9 board members. 7 of those have to have an active LEHS license, environmental health specialist license, and they represent different sectors of the profession. We have somebody from MDE, MDH, some local health representation, private industry, and so on, a couple at large. And then we also have 2 consumer reps that don't have to be licensed or are not licensed. Our board staff consists of executive director, which is me, and 2 administrative personnel. So that gets me down to what does the board actually do? So our mission is to protect the citizens of Maryland and to promote the quality of public health aspects of the environment by licensing these health specialists, by setting standards for the practice with regulations, legislation, and receiving and resolving complaints from the public. This past year, we actually had 0 complaints. I started last July in my position, and we typically have very low numbers of complaints. I think the most we've had in a number of years is 5, but it's usually 2 or 3 in a year. We don't have our licensees. There's 510 licensees this year, 523 if you include seasonal. And so we don't have a lot of licensees, but so we don't have a lot of complaints. But when we do, we take that there's a formal disciplinary action that we go through, a process that we go through, and work those out. Let's see, the board staff. Our job is to implement any decisions that impact our profession that are made by the board. We do the day-to-day activities, coordinating all the administrative activities, reviewing the transcripts, like I said, issuing certificates, issuing licenses, and so on, doing the renewals, and reviewing continuing education hours. We're just in the midst of our audit for that. And then we also do benefit from financial, legislative, and regulatory and IT staff that we share with other health occupation boards. Others have referenced that already. So I think that's all I had to say, if anybody has any questions.
All right, any questions for Lee? And thank you, Lee, for starting with the explanation, because I'm sure I wasn't the only one who wasn't sure what your board did, so thank you. Any other questions? All right, Lindsay, the next one.
All right, next up is long-term care administrators. Then I'm going to nursing and optometry.
Thank you.
I think there's a fact sheet.
Yep, I am hitting share now. There we go.
Perfect. Thank you. I'm going to actually, that has more details about our board, but I'm going to just have a few talking points that I'm just going to go over. I want to start by saying good afternoon, Delegate Kaiser and members of the commission. My name is Linda Burrow-War, and I'm the Executive Director of the Maryland Board of Long-Term Care Administrators, BLTCA. I've worked for the Maryland State Government for more than 20 years, including 17 years in aging and long-term care services and supports. The Maryland State Board of Long-Term Care Administrators has a unique and critical role in protecting Maryland's most vulnerable residents. The board licenses and regulates nursing home administrators and as of July 1st, 2026, assisted living managers. We ensure that individuals responsible for managing these facilities are qualified, competent, and accountable. The board currently oversees more than 1,450 active licensees, with approximately 400 additional assisted living managers licensees anticipated by October 2026. So we've definitely grown from that 488 active licensees that was presented earlier in just a short period of time. What makes BLTCA unique is the scope of the professionals we regulate. Nursing home administrators and assisted living managers are not responsible for a single clinical service. They manage entire residential care environments where people live. Their decisions can directly affect resident safety, quality of care, staffing, services, facility operations, and the residents' overall quality of life. In addition to receiving consumer complaints, BLTCA receives on-site survey reports from the Office of Healthcare Quality, OHCQ, the state's licensing authority for nursing homes and assisted living facilities. When those reports identify potential violations involving an administrator or manager, BLTCA treats them as complaints. This creates an important connection between facility-level oversight and professional accountability. As the number of regulated professionals continues to grow, BLTCA's role is increasingly important, not simply as a licensing board, but as a critical part of Maryland's system for protecting residents, promoting competency, and ensuring accountability and long-term care. I want to thank you for the opportunity to allow me to speak today, and if you have any questions, please ask. Thank you.
Thank you. Any questions? As I have trouble refinding my video. All right. If there are no questions, Lindsay, to the next board.
All right, hopefully you can all see the Board of Nursing. And Dr. Forbes Scott is here on behalf.
Thank you. Good afternoon. Can everyone hear me?
Yes.
Okay, thank you. Good afternoon, Delegate Kaiser, members of the commission. My name is Camille Forbes Scott. I'm the Deputy Executive Director here for the Maryland Board of Nursing. I thank you for the opportunity to provide an overview of the Maryland Board of Nursing on behalf of the Executive Director, Attorney Rhonda Scott. The Board of Nursing is a 14-member body that is responsible for protecting the public by regulating nursing practice in Maryland. It operates under the Maryland Nurse Practice Act and oversees more than 214,000 active licensees and certificate holders as of today. Note that that number does not include temporary licensees and certificate holders, expanded roles, or sub-certifications. In 2023, House Bill 611 granted the Secretary of Health authority over the board's infrastructure, operations, and staffing through July 1st of 2025. And then in 2025, House Bill 19 extended the Secretary's oversight of certain staffing and infrastructure functions through July 1st of 2030. Although we're called the Maryland Board of Nursing, our responsibilities extend well beyond nurses. In addition to registered nurses, licensed practical nurses, and advanced practice registered nurses, the board regulates certified nursing assistants, certified medication technicians, certified dialysis technicians. We also oversee licensed electrologists, licensed direct entry midwives, and licensed certified midwives. This broad regulatory authority distinguishes Maryland's Board of Nursing from many traditional boards of nursing. Core responsibilities, of course, includes processing initial and renewal application, endorsements, reinstatements, and examination applications. We also receive and investigate complaints and take disciplinary actions when a licensee or certificate holder violates the Nurse Practice Act. One of the most significant ways our board differs from others is our role in education. We review and approve new and existing nursing education programs and certification training programs. Board education consultants conduct site visits, evaluate faculty qualification, and monitor programs for continued regulatory compliance. Maryland Board of Nursing is one of the only 5 nursing regulatory boards in the nation recognized by the United States Department of Education as a reliable authority on the quality of nursing education programs. The Maryland Board of Nursing has also demonstrated national leadership in protecting the integrity of nursing education. During Operation Nightingale, the board worked with federal partners to identify and investigate individuals who may have obtained licensure using fraudulent nursing credentials, or investigative methods, triage processes, and tools received national recognition and were shared with other boards of nursing. We are equally committed to workforce development and stakeholder engagement. In 2023, and more recently in 2026, the board received recognition from the Welcome Back Center of Suburban Maryland for assisting internationally educated nurses in obtaining Maryland licenses and certifications. The board also have started to conduct town hall informational sessions, office hours, and recurring meetings with nursing associations, chief nursing officers, educators, and other stakeholders. Looking ahead, priorities include strengthening staffing, implementing our second phase of fees increases, which will be training program fees, expanding quality assurance, modernizing operations via information technology, and improving constituent services. The Maryland Board of Nursing is the first health occupation board in the state to implement the new licensing system, the MDH Centralized Health Accreditation and Registration Tool, otherwise known as MDH Chart. And we continue to work to digitize and streamline all our processes. Ultimately, the Maryland Board of Nursing is more than a licensing agency and more than a regulator of nurses. We believe we are an education oversight body and an enforcement authority, a workforce partner, and a public protection agency serving a diverse range of health professionals and the people of Maryland. Thank you.
Thank you so much. Thank you for that presentation. I wanted to ask you the same question I think I asked the acupuncture board, the question of, and I guess this would have been relevant to a few other boards as well, with so many different types of licenses that you oversee, how broad is your board in understanding those different fields?
I think the answer is probably similar to the response you got earlier. The board has a mixture right now. One of the things the board has not had recently in the past few years has been the LPN, licensed practical nursing member. We have 2 seats for those positions, and those have been empty for a couple of years. So I know we're working to actively recruit for those seats, but I think generally we do have a mixture of a representation of everyone on this board. And although we do not have a certified nursing, a certification member on the board, we do have a CNA, a certification advisory committee, which is statutory. And so we have oversight there as well.
All right, thank you. Any other questions? All right, Lindsay, back to you.
All right. Next we have optometry, then we will go to pharmacy and PTs. And I'm going to pull up the optometry presentation. Where's right here? All right, and please feel free to say next slide when you'd like me to move along.
Good afternoon. My name is Gwendolyn Joyner. I'm the Executive Director for Maryland Board of Examiners in Optometry. I've been with the board for 4 years. I've worked with regulatory boards for 22 years throughout my career in state government. We are currently a staff of 2 people, myself and a licensing specialist, and we also share staff, IT, legislative liaison, regulations coordinator, and fiscal staff. The Maryland Board of Examiners has been in existence, was created in 1914. We have a board that is consisted of 5 ODs and 2 consumer members. The board's mission statement is to protect the citizens of Maryland and to promote quality healthcare in the field of optometry by licensing optometrists, receiving complaints and resolving complaints, setting standards for the practice of optometry. Next slide, please. Here you'll see the historical perspective of the board. Laws regulating the practice of optometry in Maryland became effective in 1914, diagnostic certification 1990, special fund status 1993, and to add, the board has not increased fees in 25 years. Therapeutic certification quality assurance program became effective in 1995. Contact lens legislation 1998, administration of topical steroids 2005, and the illegal sale of cosmetic contact lens law in 2014. Scope expansion law went into effect in 2019 for independent management of open angle glaucoma, corneal and conjunctival foreign body removal. Next slide, please. What is different about the optometry board? It's somewhat unique among the Maryland's Health Occupations Board to its structure, how members are selected, and the specific scope of authority it holds over the profession. For each optometry vacancy, the Maryland Optometric Association should notify all licensed optometrists in the state of the vacancy to solicit nominations to fill the vacancy and conduct a balloting process where every licensed optometrist is eligible to vote to select the names of licensed optometrists that will be submitted to the governor. Next slide, please. Who do we regulate? We regulate diagnostically certified optometrists, non-certified, which means they're neither DPA or TPA optometrists. The non-certified optometrists cannot prescribe or administer topical therapeutic or oral medications. Next slide, please. We currently have, as of today, we have 983 therapeutically certified optometrists, diagnostically certified optometrists 33, and as of today, we have 26 non-certified. The board is in the process of working on new legislation to make some changes to the scope regarding DPA and non-certified. What regulatory boards do not do: act without statutory authority, comprise neutrality, manage and violate professional compliance. Next slide, please. Thank you all for your time today. Any questions? Thank you.
I don't have a question. I would just say when you mentioned the sharing of staff for certain things, I mean, I think that leads into maybe our later discussion of what does make sense for maybe some boards and not some others of sharing of certain administrative tasks, and are there other opportunities for that type of scale? So holding on to that thought for later. Lindsay, back to you.
All right, next we have the Board of Pharmacy, and I will pull up their sheet, which is there. It's in Word.
Okay, good afternoon, everyone. I'm going to talk today and focus mainly on the work of the board as it relates to public safety and collaborations with federal agencies and local stakeholders. Our board, particularly under my leadership, has been very focused on the public and public programs. So that's what most of my report is about right here. My background has primarily been in health education, administering health programs. I worked with Maryland Medicaid. I also worked with the immunization program and was the Vaccines for Children chief for the immunization program for several years, for 8 years. And I also did Medicare education with AARP Maryland. So my whole career has been basically focused on direction and administration of health programs. So in the report, I start off by saying that the mission and the vision of the Board of Pharmacy is to protect the public, as I said, and advance the practice of pharmacy. The board has furthered these goals in several ways and has received national recognition from the National Boards of Pharmacy in several key areas. So we work very closely with NABP. The first thing is the Wellbeing Champion Program. So we were recognized nationally for having applications that do not include intrusive mental health questions. So that's a big deal nationally, is making sure that we're not turning people off by the application questions that we're asking so that we can make sure we're keeping up our licensee population. We're maintaining it. The next is drug safety interoperability. The board has been a part of the pilot group of boards across the nation that met with national drug manufacturers and distributors to develop a drug tracking system to assist in preventing diversion activity. As a result of these meetings, NABP developed the Pulse Drug Tracking System, which is in operation currently and currently being used in pharmacies, distributorships, and manufacturers in Maryland and across the country. Our inspectors for pharmacies can also use this tool when they go out as a tracking tool. And as we investigate more and more investigations that we're conducting of suspect activity in pharmacies, we actually now have a really good tool to track the drugs that are in the pharmacy. So that's also a big deal. The other thing is the pharmacy school law exam. The Maryland Pharmacy Board, along with 9 other state boards, piloted a new federal law exam that several University of Maryland students have taken and passed for the first time this year. This exam will allow students who take the exam and pass the clinical exam to practice in not only their own state, but in other states that offer that particular exam. This creates the possibility that Maryland may significantly increase the number of pharmacists who select Maryland as their practice state. So we're looking to that actually to increase the number of pharmacy practitioners and pharmacists that we have in our state. So then I go on to talk about several agencies that I have board partnerships with. You can look at that. And then finally, board achievements, the programs that we've implemented over the past 10 years since I've been here. Contracepting, prescribing. The board brought together stakeholders from pharmacies, Planned Parenthood, Medicaid, and other groups to develop the pharmacist contraception prescribing program in Maryland. The board has certified pharmacists with contraception prescribing authority for the past 3 years and currently has over 1,000 licensed prescribers. The Vaccination Authority for Pharmacy Technicians. For the past year, the board has certified pharmacy technicians to administer vaccines in pharmacies. The program currently has close to 2,000 pharmacy technicians certified in this program. That's a really big deal because it helps the pharmacists to be able to use their skill set in terms of counseling for their patients, in terms of advancing and promoting other aspects of pharmacy practice, if they can have technicians actually helping out with the vaccination. So that was a really big deal. Prescription labeling for vision impaired. The board has provided pharmacists training and monitoring for this new service to the public effective in November, not next month, but in November. The board's continuing education program can be viewed using a link from the board website. So I encourage you to go to our board's website, click on that link, and you can learn more about the prescription labeling for vision impaired program. We actually had that CE event for pharmacists so that we're making sure that our population is adequately prepared to administer the program. And also the VAEIA program that came, a governor's program that headed that up. We also have pharmacists that are registering for that program. We have a pharmacy technician seat added to the board. So prior to a couple of years ago, we only had pharmacists and consumer representatives on our board. And now we have a pharmacy technician for the first time that's on our board. So that brings our total number of board members to 12. Board member seats represent several different areas of pharmacy, including acute care, long-term care, retail chain, and consumer and at-large seats. And finally, we added public board meeting streaming services to the in-person option. Now we've doubled the number of meeting attendees in our public board meetings. So we've made a lot of advances. We'll continue to do that. At the bottom, we talk about our future projects, which include installation of a new IT network, use of Salesforce as our new licensing system, use of voice over IP as the new customer service platform, and provision of free pharmacy law book direct shipments to Maryland pharmacy schools. And that's my report. Thank you. Are there questions?
Anybody? All right, next presentation.
All right, next up, we are going to have the Board of Physical Therapy Examiners, and next will be Board of Physicians, and then the Board of Examiners of Psychologists.
And I'm going to apologize. I don't know why I'm purple. I guess I'm representing the world at this point. So can you all hear me?
Yes.
Okay, I'm going to turn my camera off so I'm not looking purple the whole time, if you don't mind. I apologize. So good afternoon. I'm Lori Kendall Ellis, the Executive Director of the Maryland Board of Physical Therapy Examiners. Our mission, as you can see on top, is to ensure the Maryland Physical Therapy Act and its regulations effectively safeguard the health, safety, and welfare of all Marylanders. So I'm going to start out with pointing out our performance. We meet 100% of our managing for results objectives with zero audit or repeat audit findings and no licensing backlog. Our operations are fully digital, serving nearly 10,000 licensees, and complaints make up less than 0.4% of the total licensee base. Turning to governance and authority, the board is governed by 9 dedicated board members, supported by 9 operational staff and 7 shared specialized staff. We're also a member of the Interstate Compact, which gives Marylanders a flexible, resilient healthcare workforce. And importantly, we're entirely self-funded through licensing fees with no general state tax revenue. Our fees allow us to meet our expense obligations while additionally earmarking funds to modernize our technology. Finally, recognition of what sets us apart. The Federation of State Boards of Physical Therapy has recognized us with an Excellence in Regulation Award, and we hold top state ratings for consumer protection. We report public disciplinary action in an average of 8 days, reflecting our commitment to transparency and public trust. And each year, we publicly present our fiscal year-end report and hold an annual strategic plan meeting. I want to thank you for allowing me to have this time with all of you and invite you to please join our monthly public meetings, which are held the 3rd Tuesday of every month at 1 p.m.
Thank you for that invitation. Any questions for our purple member of our commission?
That is funny.
Thank you.
All right. Who's next?
The next is Board of Physicians. Then we'll have the Board of Examiners of Psychologists and the Board of Social Work Examiners.
Yeah. Hi, everyone. Christine Fairley. I'm the Executive Director of the Board of Physicians. I just kind of threw together an infographic, and it includes a lot of statistical information. So I definitely do want to take the opportunity to also brag about the board's performance and efficiency. We had no fiscal or operational findings in the audit. We do consistently meet or exceed our managing for results goals. But our focus kind of goes beyond meeting those benchmarks. We're always looking for ways to improve efficiency. And I can give you a quick example. We had where we had reduced the number of days to 17, and we're like, what's holding us at 17? Well, it turned out to be the receipt of criminal history record checks. So we rewrote all of our directions on the website and told people they had to have it before they applied, made them check a button, and we were able to bring that down 5 additional days. So, we go back and look, what's not working, what's working. So I do want to say that technology is actually one of the board's greatest assets. The board developed and owns its own information technology system called BPQA. It's fully customizable to our needs. When laws or processes change, modifications can be made quickly without like exorbitant costs or without waiting years. So we own the source code. We've offered BPQA to the other boards. You know, it would be literally free of charge. They would just need to pay a programmer to customize. It does everything: licensure, discipline. It does PIAs. We have different fiscal components. So we have all these different components. And again, it changes every time the law changes. We're able to change our system pretty much before the law even goes into effect. The board also funds programs, and this is just one of my pet peeves that I'm going to just bring up. We fund programs and we really have no control, and we don't have any adequate accountability. I'll give you a few examples. The first is we fund OCSA. They do physician dispensing permit inspections, and you can see on our infographic how much we pay per year. However, we never get, even though we request, we never get the actual cost of those inspections. So as of today, I still don't know. But meanwhile, we're just giving them money. The other thing that the board funds is 13.5 positions at the Office of the Attorney General. Only one of these positions works 100% for the board. So really the remaining 12.5 positions support other Health Act boards and MDH units, you know, that don't fund them. So it is frustrating for us because these positions are included in the board's PIN count. So you're gonna, like, the legislators look at our total PIN count and they won't give us more staff because they see that we have these additional 13.5. And it's also frustrating because if they have a vacancy, they don't even tell us. And then it contributes to our vacancy rate. So, you know, that's one of the things that, again, is one of my pet peeves. I did want to just briefly address shared services. The auditors said that the boards don't share services, but I took a look and I had my fiscal director pull it together. And this year in FY26, the Board of Physicians' indirect cost was over $2.3 million. So these costs really do demonstrate that the resources and services are in fact being shared, or at least the board is paying for them. The key question I think here is not really whether resources are shared. It's whether the costs charged to the boards accurately reflect the resources and services we receive. So I would put that out there. So in terms of differing from other boards, we're the largest board. We have 22 members. It's split into 2 disciplinary panels. We have advisory committees. So instead of our board being made up of each practitioner type that we license, we have advisory committees made up of those individuals, and they provide advice to the board. Again, we have our own licensure and disciplinary system. We host our own website, and that's something that we are really proud of. We provide resources for applicants, consumers, licensees. One thing that we do that I don't think other boards do is we have a practitioner profile for each licensee, and it contains like a lot of information: what school they went to, whether they have malpractice claims, whether they accept Medicaid, you know, and this is it's a really good resource. All of like credentialing agencies use it. And, you know, also consumers if they're searching for an individual practitioner. The other thing we do is we delegate our hearings to the Office of Administrative Hearings, OAH, for a proposed decision. Our board just doesn't have time to do a full hearing. So that's something that does cost us a little more money. We do have specialized staff classifications. They're called MBP, Maryland Board of Physician, either licensure analysts or compliance analysts. They also have advanced training, and they have a certification, like certified medical board licensure specialist, or investigator. So many of our board's other differences are statutory. So, because I endured and Lindsay was part of several sunset reviews, and we had an independent review come in and review our board. We've made significant improvements, and I mean, it has been since the 2011, was really a crucial turning point for the board. But I reviewed our statutes and looked at what are the provisions that have been helpful in keeping us on track. So this is where my recommendations come in. One of the things that we've done is delegate the duties to the ED. That's in our statute and staff. So I can give you another example. Before I was at ED, they used to actually have the board members look at each licensure application, even after they met minimum qualifications and could be issued a license. And then sometimes board members had questions that weren't within the scope of the board. We would ask the practitioner the question and, anyway, what we did was I asked the board to delegate that to staff. And this is, of course, a clean application, meaning no investigation is necessary. So we've now almost, our mean time is 12 days, for issuing a physician license. And as the chart shows, it's down from 53. And if we also have some expedited pathways, and those licenses are issued generally within 3 to 7 days. So I think we're really improving there. So delegating duties where the board does not have they can't make a decision. The decision is made in the statute or regulations. That's been really helpful for us. One of the other things that we have in our statute is we have a time frame for complaint disposition. So we have to finish our cases within a year. And if we can't, we have to put documentation in the file about why we can't finish it. And this really has kept investigations moving. It identifies delays caused by external sources because it's not always our problem or our fault. So this is something that I think our investigators keep in mind, when time is coming up. And Lindsay can attest, I think, that our investigations used to take 600, 1,000 days, and now we're right around a year. I'm finishing. Okay, so one of the things that I would like, annual reporting requirements. Our board in 2020 had kind of a revision of our annual reporting requirements, and it includes specific licensure and disciplinary indicators. And I think like application volumes, complaint timeframes, actions, cases over a certain period of time. I think something like this for all boards, because not all boards have a requirement for an annual report. So I do think something like this across the board, everyone reporting kind of the same thing would be very helpful in determining like workload and some other issues. So these are kind of non-statutory, but I would like it in statute. One of the things is require the OAGs to report workload and, their personnel utilization each year. This would help us improve transparency, accountability, and budgeting. And then the next item is establish objective criteria for new professions seeking licensure. This is something that I think is really a good idea, and actually we're proposing it in the 27 session. One of the things like you're hearing now, Delegate Kaiser and others from external, is just how many practitioner types we have. And basically now people they just say, hey, we want to be licensed. And rather than looking at lesser regulation, they are licensed, they're a licensure group. And it's a lot of work. And I think everyone should be looking at lesser regulation. Like, can they just be called certified rather than immediately going to licensure? And I think that would help too, because boards are here for public safety. And I think that message gets erased. And instead, most groups want to seek licensure for billing purposes. So they're using the board for billing, purposes, really, instead of there being a public safety risk. One of the things that I know I asked and some of the other executive directors asked was why can't DLS through their audits actually report what finding went with what board? And this is the whole, like, we're all lumped together. So, it's very difficult, even at the hearing, the JAEC hearing, it's the Health Act boards, and it's not really true, so it would be really helpful. And they said, oh, it's a lot of work, but it really would be helpful, even as a footnote. These boards have, this issue, these boards have this issue. And then finally, it's giving each health occupation board a formal opportunity, like through this mechanism, and I appreciate the opportunity to identify, like, what are our technology needs, what are our staffing needs, what are our operational needs.
I think you're getting into the work
Oh,
plan.
I'm done. That was it.
Yeah.
So thank you.
Okay.
That was it. Thanks.
Any questions? All right, Lindsay?
The next one I have is the Board of Psychologists, and I do not have any kind of visual for that one.
Okay, go ahead.
Hello, everyone. My name is Tamika Davis, and I am the Deputy Director and Licensing Coordinator here at the Maryland Board of Examiners of Psychologists. I'm speaking today on behalf of the board because our Executive Director's position is vacant, and it is currently being recruited. Just really briefly, we here have two professions, one of which is for licensure and our Registered Psychology Associates. In total, we are one of the smaller boards. We have about 4,400 licensees. To become a psychologist in Maryland, you must have a doctorate degree, and it must be in clinical counseling or school psychology, or a doctorate in education and counseling or school, and it must be from an APA approved program. To become a psychology associate, your minimum educational requirement is a master's level degree in either one of those same education concentrations, which is a clinical counseling and school psychology, or a master's in education that specializes in counseling or school psychology. A frequent caveat or something that we encounter here at the board is that we have a lot of online programs, which are convenient for various reasons. However, most do not meet the minimum educational requirement to become a licensed psychologist in the state of Maryland. Our board consists of 9 board members. 7 are active licensed psychologists. 2 are consumer members. We have 4 committees, which is our licensing, regulation, legislative, disciplinary, and our public relations. We do have 6 staff members here. That does include our executive director's position. We have online applications for our licensure and renewal applicants. Complaint filing is also initiated online. Once all requirements are met, licenses and registrations are issued within 10 business days. And just a little snippet of the history of the board. We were established in 1981. The authority for the board's functioning comes directly from the Psychologist Act, which was enacted into law back in July 1st, 1957. And does anyone have any questions, comments?
Doesn't look like it. Back to you, Lindsay. I think the last group.
Thank you.
Yep. So our last health occupation is the Board of Social Work Examiners. But I did also hear that there might be someone here from the Kidney Commission, which is not a health occupational board, but might want to speak. So if you are here from that, just hold on a moment and raise your hand when we're done with the social workers. Thank you.
All right. My name's Karen Richards, and I am the Executive Director at the Board of Social Work Examiners. I've been here since February 2024. I've also worked as a licensed social worker in Maryland for over 30 years. I've actually held every 4 of the licenses that we issue. I also served on the board for 6 years. Our board, again, when our board was established in the late 70s, I want to say 78, very much modeled. It was interesting seeing Lindsay's earlier presentation because the social work board, Sinai Hospital, University of Maryland School of Social Work were very involved in establishing the board. And so our board is kind of made up a lot like the physicians, following the medical model. We have 12 members. The members of the board, 10 are social workers. They represent the diverse professions that social workers work in, and the diverse areas. So we have a member from Southern Maryland. We try to have someone, again, because the social work's practice in one of the rural areas is a little different than practicing in Baltimore City. I have some numbers on this sheet. These numbers, I just put in the numbers for the managing for results for fiscal year 26. So these numbers are very current. Our board continues to grow. We currently have over 21,000 active social workers. I also have some numbers down there that just came out because we were one of those identified boards, in particular around complaints. We take a large number of complaints. In fiscal year 26, we had 194 complaints. We initiated 121 investigations. We completed 113 investigations. That's a 93% completion rate, which is up from 79% in fiscal year 25 and 58% in fiscal year 24. How do we do that? If you get to the next page, we were able to secure 2 new PINs for 2 new health investigators. When I came in, I filled all the vacancies. We also had which included hiring 2 new health investigators. We also had a backlog in license processing. And so I hired 2 part-time contractual positions in fiscal year 25. One of them came on and is now working for us full-time, but those part-time staff were able to address our backlog of applications. We are now processing licensing applications within 45 days for the LCSW-C, which is the most complex application to process. So we are well within the 90 days that's mandated in our COMAR. In the last 2 years, our board has had 2 significant pieces of legislation. Fiscal year 20, legislative session 25, the Social Work Compact was enacted. This is going to eliminate barriers for Maryland licensed social workers so they can do telehealth with clients in other states. It'll also increase the access to Maryland citizens, particularly in the rural and underserved regions. As of July 2026, 35 states have joined the compact, including neighboring states, Virginia, West Virginia, and Delaware. Unlike some other professional compacts, the social work compact, those Maryland social workers are going to have to apply through our board in order, and then we will send to the compact commission. So this is going to add another layer of license that our staff is going to have to process. In the last legislative session, the provisional licensing bill was enacted. This will allow LBSW and LMSWs to be licensed and to begin practicing after they graduate from an accredited social work program. This will help the workforce because this will put the newly graduates right into the workforce, and they will have time to practice as a licensed social worker as they prepare for the licensing exam. A couple other things that we were recently doing to improve efficiency at the board. We are going to be enacting an internal continuing education audit. We used to contract with an outside provider. With help from the Board of Physical Therapy Examiners, we're modeling their smart sheet model, which will give the board a cost saving of about $15,000 annually. Additionally, when I came in, this board had boxes and boxes and boxes of paper files. We have steadily worked on that and working with the Maryland State Archives. Our board is working to digitize. Right now, we're at the end of the summer, we'll have over 100 boxes of compliance files digitized. Real quick, we do have 17 full-time staff, and then we do have 1 part-time staff member who works under the executive director. Any questions?
Can you go back to page 1?
Yep.
Oh. I was curious, I don't remember the exact numbers, 193 complaints filed, but that wasn't the denominator. 194.
Yeah,
But then
194.
the investigations initiated and the investigation completed, that 93% is the 113 over
Yeah.
121. What
Correct.
happened to the 194?
Many
Why
are
that's not part
dismissed.
of it?
Many complaints are dismissed without an
Okay.
investigation.
Okay, thank you. All right, well, that was a simple question. Any other questions? All right, Lindsay, you said we're gonna hear from one more group?
So I did hear that there is interest in hearing from the Kidney Commission. I will also just note real quick, just to give the full picture, the other boards that we didn't hear from, and this was not mandatory, the Board of Chiropractic Examiners, Dietetic Practice, Massage Therapy Examiners, Podiatric Medical Examiners, and Professional Counselors and Therapists. So that's the full picture of the health boards.
All right, we have a lot of questions, and then I have some things as we get to the next steps part, but let's go in order of the hands. Eva.
Thank you, Delegate Kaiser, and Lindsay, thank you as always. I'm Eva Schwartz, Executive Director of the Maryland Board of Podiatric Medical Examiners and the Commission on Kidney Disease. In order to honor the time and not to overexhaust everyone, all I'm going to say about the Board of Podiatry, that they meet all the MFR standards. And this year, the legislature has passed a bill that the Board of Podiatry will enter the compact. So that's our most exciting thing that we have to work towards. And I appreciate you allowing me to say a couple of words about the commission. I've been with the commission for 35 years. It's like family to me. It's a very important branch of the Maryland Department of Health, and I work directly under the secretary for it. And we do extensive outreach into the community. It is a socially and economically burdened community. And it's important that the commission survives in order for all these patients to continue to have access to funding for their care through the Maryland Kidney Disease Program. All of that has to happen if the commission could certify renal dialysis facilities. And for that, we need funding. We have been in the rears in being able to accommodate all the funding with the increases that the department adds to the commission. And we requested legislatively, this is our second year to allow us to increase our fees. And the industry is amenable to that to support us. So the patients, it's a direct impact on the patient that they could get funding from the kidney disease program to take care of their transplant meds, and the dialysis and transplant care. Thank you so much for allowing me to get on my soapbox as well. Thank you.
All right, thank you. I think next we have Tiffany.
I just wanted to share that the executive director for Chiro and Massage, Sharon Oliver, is in the meeting, and she did have a 1-minute presentation she wanted to share.
Okay, we'll jump to her. Ms. Oliver.
Good afternoon, everyone. I hope you can hear me. We were experiencing some technology issues earlier with the mic. If you are having problems, let me know. But I'm Sharon Oliver. I'm the executive director for 2 boards, the Chiropractic Board and the Massage Therapy Board. These boards were joined, and in 2016, the legislators broke the boards apart. What's unique about this situation is that both boards share the same staff. And part of that was mandated as a result of one board not being able to financially support itself independently. Since I joined in 2019, both boards have made some significant progress. As with some of my fellow colleagues in the last legislative audit findings, we had no deficit findings. And this was unique for our boards because we have had some serious findings in the past. the boards have worked very diligently and to ensure that we have no audit findings. And hopefully this is the same going into the future. Some of the unique things that the boards have done is we went from paper. We now have digital licenses. We are now online with applications processing. And this has made a tremendous difference in the processing time for our applicants and for renewals. The boards have taken some significant initiatives in the state, and these initiatives have been recognized nationally. I can think of the Massage Therapy Board, where this board is the only massage therapy board in the country, in the nation, that has a law on the books that makes it a felony to aid and abet in the unlicensed practice of massage therapy. And consequently, we were recognized by the CLEAR organization, the Council of Licensure, for the regulatory and legislative work that we do in this state, and that we are an example to other boards nationally. The Chiropractic Board has done something very similar in that it updated its regulations and its statute to reduce the barriers to entry into the profession here in the state, with the hope of increasing the number of individuals who can participate in the workforce here in Maryland. And we have also, launched our system here internally to ensure that we can process as many applications as we possibly can to meet the MFR standards. And we are proud of the work that both boards have done. Both of the professions are drugless professions to ensure that we can assist our citizens to wellness. And that is one of the unique aspects of both boards, where we are drugless. And we know we have a number of individuals that suffer from pain. We help with pain management, and we hope that this continues to ensure that we can fight the opioid epidemic in the state of Maryland. With that said, I thank the commission for allowing the boards to have a voice and to help educate on what we do. There are a number of, key issues that we would love to address. I want to say that I work with a wonderful group of executive directors. We collaborate as much as we can to ensure that, as we say, a rising tide raises all ships, and that's how we are working together. Contrary to what some individuals may believe, this group of executive directors and other administrators, we support each other as best as we can. We share staff, we share resources, and I am very proud to be a part of this excellent group of administrators. And with that, I am complete, as we say in massage.
Lindsay, who's next? I can't see the screen right now to call on I think a gentleman who had his hand up.
Yep, I see one hand, and I'm sorry, I'll butcher your name if I try it. Would you please introduce yourself?
That's me, Tomiloba Olani Ikodri. I'm from the Board of Professional Counselors and Therapists. I'm the Executive Director. I would like to just briefly speak about our board. Our board is unique because we regulate 5 distinct professional categories: professional counseling, alcohol and drug counseling, marriage and family therapy, art therapy, and behavior analysis. Across these different categories. We have about 12 different licensing, certification, and trainee categories. And we also oversee about 16,000 active credentials. This responsibility is carried out by about 13-member board and also a staff size of about 16 employees across the licensing, compliance, and administrative and executive operations. I work as the ED. I have a deputy director, and we also have heads of unit. Well, the head of unit for the licensing team and then the compliance team. Our workload is quite substantial, and in recent months alone, we've received over 174 credential applications. In addition to that, there are also supervisor application, pre-applications, out-of-state applications, and so on. Since becoming the executive director, one of the things I've focused on from the very early stages, trying to modernize the board. On my very first day, talking to the board secretary, I figured out that we were still doing paper payments, paper applications, and things like that. And obviously, that kind of affects the efficiency of the board in terms of being able to process applications quickly. Another problem that I noticed at the very early stage was that we didn't have enough staff. We didn't have enough coordinators, enough administrative staff to even help with the task at hand. So thankfully, I was able to collaborate with some of the other EDs, and they were very helpful, particularly at the board of massage. We were able to collaborate. She took me under her wing as a mentor to help us get out of that problem a little bit. So right now, in collaboration with the board of massage therapy, we've been able to replicate the online application processing system that they have to help us begin to take online applications. As a matter of fact, we launched this online application system for our own board a little over a month ago, and within that short space of time, we received over 100 applications on that system. And we've also been able to eliminate paper checks. The issue of paper checks is one of the things that came up in the evaluation of the board, because there were a lot of cases of, even for the audit report, returned checks and issues like that. But because of this online payment system, all of that problem, we've been able to put it behind us. Right now, what we're doing is we're trying to work to clear the paper application backlogs that we already have on ground, so that we can begin to fully use the back end of this new online application system. We've also recruited additional staff. We've tried to improve the application triage system, internal case tracking, and also expanded the opportunities for public participation. One of the things I put in place when I joined the board was we began this stakeholders engagement, quarterly stakeholders engagement, which allowed us to be able to be transparent with members of the public and also be able to hear feedback and the review of part of the things that we are doing. We will also be able to share ideas with those stakeholders, particularly now that we are in the middle of the comprehensive review of our regulations. We've realized that there are some regulations in the way we do our business that stand in the way of our ability to process applications faster and get people their licenses. So we've been working with those stakeholders, working internally to make some changes to these regulations that would overall improve how we do our business. I'm proud of the progress that we're making so far. We know that where we want to be is still a bit far from where we are, but gradually we are moving forward and we are taking major steps to achieving our goal. Thank you very much for the time.
Thank you. Are there any questions from that last presentation? Great. Lindsay, I know from the agenda, the next thing on our agenda is next steps. And I wanted to kick that off by first thanking everyone who was here today, thanking everyone, and especially Tiffany for 5 presentations. But thank you all for, as somebody already pointed out, advancing public health in our state. I was taking a lot of notes during the meeting. I'm sure others were as well. A lot of themes popped up for me, a lot of questions that I wish I knew about every board. But this isn't about creating a matrix of 10 variables or 20 variables. It's certainly deeper than that. Everyone's presentations were mostly on the plus side. So I know that, but several of you did share challenges and opportunities, and I hope we hear more of that. Thematically, I'm wondering about funding and staffing. Several boards mentioned not increasing their fees over the years, and if that's a direction or a conversation, or why some boards seemingly are well staffed and some are understaffed. I also think really coming back to the name of our commission, in terms of next steps, the conversation could be about what should be centralized, what should not be centralized, and then also, if centralized, which things might be required and which things might be optional. So to me, some of those are some of the broader themes we might have conversations about, but I certainly welcome any comments, questions, reactions, and anything that Lindsay, that you have for us as well.
Well, looking back at my notes, in the last meeting, we identified a few broad categories that might be sort of the theme of upcoming meetings. I recognize that so many of these things are inextricably intertwined with one another. What I had on my list was IT issues, including licensing and complaint processing software as one. HR issues, including staffing. Org charts was something that we weren't able to cover today, but I think would be covered because there's a big difference between a staff of, I don't know exactly, Christine, I'm going to say something like 70, but I know that includes your 13 and a half OAG pins and versus 2, right? Like those are pretty big staffing differences between boards. A third topic was administrative procedures, including legal. So maybe getting to those OAG pins, legal issues. And then a fourth that I had listed previously, this does not have to be an exhaustive list by any means, is budget issues, including fee setting, fund balance transfers, which I know is a concern for some boards, perhaps all boards. So that's just 4. Like I said, that doesn't have to be exhaustive, and many of those topics might be intertwined. The other thing that I looked at is if we want to keep a monthly meeting cadence. This is the 3rd Monday of the month. Unfortunately, the 3rd Monday of September is Yom Kippur, which would have been September 21st. But we could look at September 14th for the next meeting date. That is actually almost a month away, so that's not too close, perhaps, to think about. And then the future 3rd Mondays of the month would be October 19th, November 16th, and then December 21st, which is getting close to Christmas for some. I don't know if that will be a concern. But
maybe move that one a week back early too.
I'm sorry? I'm sorry.
I was saying maybe move the December meeting earlier a week as well, just like September.
Yeah. So I was hoping to open it up to get some thoughts, feedback on a topic for next month, sort of maybe the most pressing issue, something that people are most interested in discussing, and then keeping what Delegate Kaiser just said in mind of the broad theme of where are there opportunities to centralize, where are there opportunities not to centralize, or perhaps, is centralization for some boards, but not all boards. So just to, like I said, perhaps have a theme for the meeting, and then we can also talk about who else maybe should be included in that conversation. And I recognize we have folks here who are not officially members of this commission, but I think, to the extent you've got thoughts, I think we'd appreciate hearing.
Anybody? How about just a show of hands? Who wants to address, if we're only doing one major topic at a time, who thinks IT licensing? Well, there's 4 that Lindsay mentioned: IT and licensing, HR and staffing, number 2, number 3, administrative procedures. That's a lot of things, and maybe covers some of the others. And then 4th, budget issues and fee setting. Should we take a hand vote? How do people want to Most people aren't on screen anymore.
I see Christine.
Anyone want to just speak up and be the winner? Christine?
Oh, no, I'm sorry. I'm not a winner, definitely. But I just wanted
Okay.
to say that, I guess I just am not understanding because I think the commission was formed, right, to look at centralization, but I don't think it should be like just we're driving this toward centralization. I do think the boards have been trying to share just how much is already shared, and I think, I guess I understand the, where the impetus is from, but I also, don't necessarily think that that's always the best idea. Because I mean, if you
I
look at
don't
other
think
states.
I'm gonna
Oh, sorry.
I'm gonna
Okay.
interrupt only because I'm not sure. Uh, 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 I was saying what should be centralized and what shouldn't, and I know that Lindsay repeated that. So I don't think the legislative goal is to centralize everything. It's to hear from everyone about what should and shouldn't. While in some cases we might have some disagreement, but it's not a drive to centralization by any means.
Thank you for clarifying that, Delegate Kaiser. We appreciate it.
So,
But Christine, keep. I didn't. I'm sorry to interrupt. I know you had other points to make as well.
no, I'm good. Thank you.
I did. And I'm Christine. I'm also glad. I'm glad you said that because I'm hoping I clarify. I also appreciated that during your presentation, you talked about the delegating of duties to the executive director and about having to report workload. And I think you had some other suggestions. So I think uh, uh, anything else that boards think might be a fix they need legislatively, here's an opportunity for myself and hopefully a future Senate co-chair and another one of my colleagues is on the line today, Delegate Solomon, who chairs the oversight committee. So I think if other boards have legislative fixes they would like to pursue, please reach out during this meeting or afterwards.
Christine and others, do you think it's a good idea to discuss the staffing and HR and the resources that we do share to give a picture of how we're operating? I know a part of Lindsay's presentation was showing the different models that are happening around the country and in our immediate area. Maybe do talk about how we are structured and what we're doing and exactly how we do share resources.
Yeah, and Tiffany, this is Lori, everybody. Sorry. I agree. And Lindsay, I really like that you pulled up the report from CLEAR. And we do have past reports that the state supported. We have the Government Efficiency Commission. We had the study on healthcare workforce. And I'm sure that there are other studies that the state has done. And could we pull in that information in addition to sending out a survey to see what we are sharing at this point, what boards are working together? For example, fiscal officer as just one very quick example. And I like Delegate Kaiser that if we take one topic per meeting, we can explore it fully. And I would very much like to have us address the administrative functions because they're very different among each board. And as we saw those different models, A through E, just knowing the physical therapy world, oh my gosh, there are 60 ways to do things with 53 jurisdictions. So it's a worthy effort for us to look at that particular topic, perhaps early on to clear the air and get us into some foundational conversations.
Anyone else with thoughts on, it sounds like IT licensing isn't getting any of the votes in the moment, but what should be next, the HR staffing or the administrative procedures?
I up
Administrative.
for us to take. This is Sharon Oliver. I'm thinking about budgeting and fees because there are several boards that do need to increase fees, and there is a concern about sweeping funds in the next session, especially for boards that are operating on a margin.
I
That's my
think to
thought.
thank you. I think to respect everyone's time, given that we've already hit the 3 o'clock hour, that I think certainly agreement that we're going to do these one at a time. We have 4 major topics to get us through September through December. As a survey monkey or something else, or some rationale of what the proper order is from I think mostly from a survey, because I'm not sure if we're going to get that resolution in the moment, but I think if everyone knows that all 4 of these topics at this time would be intended to be covered this year. So is that good enough for now that we've heard from a few people and then maybe reach out to everyone?
Sounds good.
Sure. I think, well, maybe rather than a survey monkey, I'll just email everybody and say, rank your order of importance. How about that? And just we'll take it from there, and we'll take everybody's top choice for the next meeting. And I also want to just point out that there's an opportunity here to invite other people to participate. So when we're talking about administrative procedures, we can also invite, well, we have 2 members from MDH, but we can also, invite as part of that MDH to give their perspective on their relationship with the boards. When talking about HR, we could invite DBM to come in and talk about that HR interactive process, because I know that for some boards, at least, that is perhaps a frustration, that interaction of working with MDH and DBM for hiring. So you can brainstorm that as well, as far as whether or not there's other entities to invite in to speak about how it's working, what's maybe not working as well as you'd hoped. So, sound good? And we'll target September 14th for the next meeting. I will also send out a meeting invite.
Thank you for that. Thank you, everyone. Thank you for meeting again during the summertime, and for putting together your very that really helped a lot of us see, for me to see what everyone's doing, and for everyone else to see what others do. So I think it was very helpful. So thank you again. All right, I'll see you all on September 14th.
Thank you.
Thank you.